afternoon. I'm Dr. Donna Arnett, past president of the American Heart Association and dean of the College of Public Health at University of Kentucky. I've just led a great session on the global burden of disease, our late-breaking clinical trial session, and I'm joined here by three panelists who are going to discuss the really exciting science we heard this morning.
Hello, I'm Dr. Allison Goldfein. I'm head of the section of clinical research at the Jaws and Diabetes Center and an associate professor of medicine at Harvard Medical School.
Hello, I'm Tom Gaziano. I head the Global Cardiovascular Disease Policy and Prevention Unit at the Brigham Women's Hospital and have a joint appointment at the T.H. Chan Harvard School of Public Health.
And I'm Dr. Sidney Smith, the professor of medicine and cardiology at the University of North Carolina.
So let's first start with the EMPA-REG trial. Tell me about that study.
Okay. The EMPA-REG study evaluated the new SGLT2 inhibitor, empagliflozin, in patients who had high risk of cardiovascular disease and type 2 diabetes. The primary findings on myocardial infarction, stroke, and cardiovascular death were published very recently in the New England Journal of Medicine. The presentation today focused on heart failure. The investigators demonstrated that the medication was associated with a lower risk of hospitalization for heart failure and cardiovascular death, or hospitalization for heart failure alone. And this was important because there's really very little that we can do to treat heart failure in patients who have type 2 diabetes. They found that the reductions, about a 35 to 40% reduction in heart failure, was consistent across multiple different comorbidities or covariates, including use of insulin, renal function, ACE, ARB use, and other medications. They also found that the reductions in heart failure or death from cardiovascular causes was reduced in individuals who did not have heart failure before entry to the trial, as well as in those who did have heart failure prior to enrollment in the trial. And this was not due to with the decrease in hospitalization for heart failure, increases in hospitalization for other causes. So this is very exciting news for the treatment of diabetes, as it represents the first drug really that has established cardiovascular safety in our patients with type 2 diabetes.
Well, that sounds like really exciting science and great news for the many diabetic heart failure patients in the world today. So let's go over to the AVITA study. Tell us about that.
Sure, thank you. The AVITA study was looking at smokers with acute coronary syndrome. Particularly, they were looking at varenicline, a alpha-4 beta-2 partial agonist of the nicotine receptor. The idea behind this medication is that it could decrease the drive of need for smoking among current smokers. The motivation for this particular study is that up to a third to half of patients who are admitted with acute coronary syndrome continue to smoke long-term. And so the idea to reduce this very powerful risk factor in this population would have significant benefits. So there was 300 patients enrolled in the trial. They were randomized to the two different medications. Patients had to be over the age of 18, admitted for acute coronary syndrome, and being a current smoker. And they were current smokers, an average 35-year smoking history in both arms of the study. At the end of the study, at 24 weeks, they looked at a 7-day period of abstinence among those particular patients enrolled. And it was about a 50% in the control arm and a 34% smoking rate in the intervention arm, or the varenicline arm. So that's about a 35% reduction compared to the baseline control in that particular study. And that has significant implications if this can be continued throughout. When challenged, the study was not powered for looking at safety events, so this is a very important initial study of this medication in the use of reductions in smoking for people with acute coronary syndrome at a very critical time in their life, but further work needs to be done to see if the effects persist and that it is a safe medication to use.
Well, it surely is a really important clinical problem. I think a very under-recognized clinical problem that they had such success. 47% of people met their primary endpoint, which was no cigarette smoking within 7 days prior to their visit. So I thought that was pretty compelling evidence that hopefully this will be a useful product. So Sid, tell me about the MI-GENE study.
Sure. The MI-GENE study is a very interesting study from the Mayo Clinic looking at whether or not the combination of a genetic risk score, which can be easily included in the medical electronic record, to the conventional risk score would actually make a difference in LDL cholesterols. In a group of patients, 200 patients were recruited and randomized, roughly 100 to each group. One group was given their conventional risk score. The other group was given a risk score which included the genetic risk as well as the conventional risk. This increased the risk in that group to about 10% compared to an 8% average risk in the group that was selected using only the conventional risk score. So these are intermediate risk patients, primary prevention, and the primary endpoint was the LDL cholesterol after about 16 weeks or so. So what they found was, and they had secondary endpoints also that looked at fat intake and physical activity, they found that the group that knew their genetic risk score, that had the combined score, some awareness of what their risk might be genetically as well as epidemiologically, did have lower LDL cholesterols. They were in the range of 97 compared to somewhere in the range of 107, 108 for the group that did not know their genetic risk score. However, when they looked at the potential cause of this, the patients who had the lower LDL cholesterol were more likely to have statin therapy, to initiate statin therapy. So the genetic risk score seems to be associated with a higher likelihood of taking statin therapy. That, of course, resulted in lower LDL cholesterols. There's no difference in fat intake or physical activity, which were secondary endpoints. My take on this study is that the more you think you're at risk, the more likely you are to take medical therapy. So in that particular instance, the genetic risk seems to be important. However, they did not use the more recent, the 2013 risk score, possibly because the study was designed before it came out. That score identifies more people at risk, so the additive value of genetic risk to that score remains to be understood. We do have a lot of pressure on our committees to look at how we can include family history genetic risk. Overall take on this, it's very interesting. We need to learn a little bit more about other factors that might be involved.
Well, with the NIH's push now on personalized and precision medicine, this does at least give us a first look at how we may be able to include genetic testing and motivate our patients better in the future. Well, you've heard 3 great studies presented this morning in the Global Burden of Disease late-breaking clinical trial session. Thank you for listening.